You're very welcome to C3 Collaborating for Health's International Seminar. We're a global health charity located in London, but working around the world. And one of the things we do is bring people together for a seminar where we listen to somebody from outside the UK. And while most of our audience may be from the UK, since like so many people, we were pushed into online events. The good thing is that means we're able to connect with people from much further afield, even within the UK, but certainly further afield. The bad thing is you don't get to taste a C3 healthy breakfast, which used to be quite famous. But you'll have to make your own, or you may even be ready for your dinner, midday or evening. But we're certainly today going to be talking about food. And it's my real pleasure to introduce Michel Nischan, who's really brought the whole idea of making healthy food available. In the UK, I think we have a rather punishing mentality, and we talk all the time about how to make the unhealthy food expensive, how to wrap people's knuckles so they don't touch the bad things. We rarely talk about how to make the healthy food easier to access and much more affordable. C3 works to prevent non-communicable diseases, and our focus is on the main risk factors: tobacco, what we eat and drink, and the lack of physical activity. And the bit that's really tough, I think, is what we eat and drink. There's so many myths, so many ideas, so many confusing messages out there. So I'm really delighted to welcome today somebody whose business is food in all sorts of ways, but in particular now, helping those who can least afford it eat more healthily. Michel, over to you. Looking forward to hearing from you.
Thank you so much, Christine. I want to thank you and all of your colleagues at C3 for hosting this important discussion, and also for inviting me along. And if you wouldn't mind, I'll get started by sharing my screen.
And this is when we all hold our breath and hope it works, and I'm sure it will. It does.
Okay. Let's see. And I am hoping that you can all see.
No problem.
Excellent. Very good. So yes, my name is Michel Nischan. I am the co-founder and the executive chairman of Wholesome Wave, an organization that was founded in 2007 to specifically address the disparities around food and nutrition insecurity in the United States. I think we all know on this call, public health professionals, medical professionals, et cetera, the facts surrounding the diet-related disease epidemic. I lost both of my parents to smoking, so realizing the power of the prevalence of diet-related disease surpassing smoking in the United States as the #1 killer of Americans is not lost on me. 1/3 of my family perished as a result of this public health crisis of smoking. So the parallels of 1 in 3 Americans being obese and struggling with the diet-related comorbidities that lead to early death is pretty critical. But I think importantly, the economic argument as well, that treatment loss productivity equal our national debt in the United States, 20% of our national debt. So within 18 years, we could actually eliminate our national debt simply by investing in and preventing diet-related diseases, which we think is a very powerful opportunity. It's one of the reasons why we founded Wholesome Wave. As a celebrity chef, I spent 35 years of my life in the restaurant business, really understanding food. As the father of 2 children living with type 1 diabetes, I made the connection to food and human health 25 years ago. This eventually led to the founding of Wholesome. In my businesses, I was privileged to work with highly multiracial, multi-ethnic workforce. Our core values in my restaurants We're based on genuine hospitality, in short, live to serve. And we really were able to unite everybody, regardless of race, ethnicity, or political leaning, behind the power of food. And it was really this power that led to the founding principles of Wholesome Wave. So we founded the organization believing that poverty should never be a barrier to or an obstacle to affording fruits and vegetables. And our CEO, Benjamin Perkins, formerly with the American Heart Association, has really distilled our core values into three very important ones: fidelity, equity, and dignity. And those three together equal FED, because it is all about food. In short, fidelity, because we engage our program participants in program design, design of research questions, so that they have a sense of ownership of what's happening in their communities relative to these issues. Equity, obviously, because we specifically target people suffering from racial, ethnic, and income disparities in the United States. And of course, dignity, because our organizations provide people with a financial currency that can only be spent on fruits and vegetables, but they can choose the fruits and vegetables they want rather than accepting a donation that happens to have whatever is in the box. Therefore, the dignity in the program. Our first program began in 2007. It was actually illegal at the time. We imagined what would happen because of the pressure on the food stamp or SNAP program in the United States to either cut the budget or to disallow program dollars to be spent on processed foods and sodas. Rather than taking that approach, we felt that we needed some kind of a carrot. So we decided to double the value of SNAP benefits or food stamps when they were spent on fruits and vegetables. Interestingly, with 55 million Americans now relying on SNAP, low-income Americans now spend about $130 billion on food annually, even though it's very thinly spread. So we really believe that there was not only a public health opportunity here, but a real economic impact opportunity to be able to engage, especially conservative members of Congress. We were successful in that, which I'll speak about a little bit later on the policy front. But our success there gave us the audacity to imagine what would happen if we created a produce prescription program to target health policy. And we asked the question, what happens if we used existing prescription infrastructure, but invested in food that's preventative in the front end, rather than paying for expensive treatments and therapies at the back end when it's too late? So we really engaged with doctors, nutritionists, social workers in public hospital and community, federally qualified community health center settings to really drive knowledge, engagement, efficacy, combine the power of the advice of a doctor and public health professionals with the affordability of the food that people need to avoid diet-related diseases in the first case. And I am now going to share a couple of case studies with you. We've done dozens of programs since 2010 when we created the program, but a couple were particularly inspiring to us. One was a 4-year program with the US retailer Target in Los Angeles. Each year there was an investment of about $800,000 to reach 500 families in Los Angeles through our federally qualified community health center partner, Eisner Health. 93% of their participants in Eisner Health were low income, 89% of whom were Latino, Latina, Latinx that we reached, and we worked through their pediatric center to identify our index patients. Our funding was a little bit thin, to drive the type of health metrics that we were hoping to drive, but we still had some pretty impressive outcomes from an economic perspective. About $500,000 a year was spent on food by 2,700 members of household. Of those 500 index patients, 83% of the patients met their fruit and vegetable guidelines at the close of the program, et cetera. This was really really important work for us to be able to demonstrate this. And then 49% of our pediatric index patients actually decreased their BMI. And I'm going to share with you, if this works, a video that Target invested in. This is the Aviles family. And now I'm going to share a program that we did in Detroit called Detroit Fresh RX. And this program was well funded enough, and then we were able to get the funding to partner with Yale's Griffin School of Public Health on the evaluation. I am going to tell you that the outcomes are embargoed, so I'm going to be sharing general outcomes as a result, and not all of the outcomes as the result. But it really makes the argument not only for how these prescription programs improve the lives of participants, but have a real impact on reducing costs of care in the system. So this is really, something that I can't wait for it to be published so that I can share everything with you all. But basically what we found in Detroit, which is a significantly underserved community in the United States, that the reductions in hemoglobin A1C were statistically significant, that when we extrapolated those reductions with other peer-reviewed studies that are significant, that 21% reduction in associated complications with type 2 diabetes were realized. Pharmaceutical intervention found that a small reduction in A1C results in cost savings of well over $1,000 per patient. And in this particular study, the savings per patient on average were much more significant than that. When we look at the opportunities of being able to share the outcomes of these programs, the way it worked with our program to double SNAP, our SNAP doubling program, we were able to create a significant network through a movement, really, working with community-based organizations in 47 states, over 400 markets and retailers, 1,400 markets and retailers. And we were able to demonstrate that participants increase fruit and vegetable consumption, that they...
No, I think your slides are stuck.
Okay, do you see the US Capitol?
No, we see the red one that you put up for your video.
Okay, I'm going to stop my share and reshare. I apologize, everybody.
No, please don't. Thanks to my colleagues for spotting it before I did.
Do we see the next slide yet, by chance?
No, you've just started screen sharing.
Okay. Let me try this, and I apologize again. How's that?
No, not there yet.
Oh,
Jake,
goodness gracious, my apologies.
Has Jake got your slides?
I don't believe he does. How are we now? No?
No, we're not there.
Okay, let me try this. My apologies to everybody. Give me just a moment and I might be able to. Let me try one more time. Do we see anything?
No, we have you starting to screen share, and that's it.
Ah, beautiful. Okay, so this should allow me. Okay, how are we now?
Done. You're there.
Yes. Yay! My apologies, everybody.
Breathe out, everyone.
I'm a chef, not a technician. Anyway, these are the outcomes. The general outcomes, just a reminder that the exact data is bargoed pending publication. But with the types of outcomes that we're seeing here, coupled with patient enthusiasm, restored dignity, this is a perfect environment when we look at improving hemoglobin A1C, reducing blood pressure, systolic blood pressure, being able to reverse trends in increasing BMI and actually reduce BMI. The environment to evaluate the implications for mental health disparities in underserved populations, we think is pretty powerful now. That we've really been able to tool these programs and design them in a way that this type of richer research protocol can be applied in this very safe, very secure, very comfortable setting for these index patients who, by the way, when they get these benefits, are spending the prescription dollars at local retailers, farmers markets, and having a measurable positive economic impact on the work. So getting back to the policy piece, can we see the US Capitol? I am now.
We can.
Yay, it's working. So we were really successful by demonstrating the positive impacts both in our program participants in the field, their changes around behavior, their enthusiasm for the program, their economic impact. We had small scale farmers and mid-sized farmers and markets make infrastructural investments to their businesses as a result of the increased sales that these programs brought, which helped us with our colleagues on the right side of the aisle, the dignity of choice, the increased consumption of healthy food, and the consumer enthusiasm helped us with our colleagues on the left side of the aisle. We got a pilot in 2014, which in 2018 has now been increased to baseline, which means it's permanent. It cannot be debated on the floor in Congress. It cannot be defunded if the government shuts down, which seems to be something that happens quite a bit here in the US these days. But that's real progress. And importantly, it includes a small pilot for produce prescriptions, which now has the attention of our health committees in Congress and in the Senate. So we're now audacious enough to believe that we can have a similar influence with health policy. So, you know, we take a look right now at the energy that's happening, similar to what we were able to do with SNAP incentives in the field and creating a movement. There are close to 500 organizations that are doing produce prescriptions. We're currently trying to bring them together because there are some who are doing the prescriptions as kind of a kitschy, cute named way of addressing food insecurity. And there are about 150 that really work with clinical partners, focusing on people that are either at risk of or facing or diagnosed with a diet-related disease or multiple comorbidities, and measuring health outcomes and impacts the cost of the system. So on the slide are a variety of ways right now that we're working with members of Congress to both get pilot legislation, but also create potential programs in Medicare as well as Medicaid. So we have leaders in the health committees, Energy and Commerce, Ways and Means, in the House of Representatives, and Senate Finance. All of these committees are critical to the passage of any health legislation that includes implications for their payer provider experience. So in short, you know, we envision a future where television commercials on health are actually based on the power of food and prevention, rather than the plethora of commercials peddling the plethora of you know, boutique medications that we see. And by the way, we don't need all of that language in the commercials because there are no harmful side effects to fruits and vegetables unless you're allergic to celery or broccoli. And I'll play you one last video and then open the floor for discussion and questions and answers.
Is your health keeping you from life's special moments? It may be time to talk to your doctor about broccoli. Broccoli releases powerful agents like vitamins A, C, D, E, calcium, zinc, and sometimes methane. Broccoli is safe to administer to children, despite what they may say to the contrary. Airplane noises may help with toddlers under the age of 5. Now, doctors can write real prescriptions for broccoli for those at risk for type 2 diabetes. Go to wholesomewave.org to help support this program nationwide. And ask about broccolini, new from the makers of broccoli.
So we'll close on that note. Now, thank you all for your patience with my technical challenges, and love to turn it back over to you, Christine, to facilitate the conversation.
Absolutely, and thank you. It's really interesting, really exciting. Lots of comments coming up on the chat. So I'll call on some people to put their question in a minute. We at C3 have been are working in an EU project, which puts a lot of emphasis on growing your own as well as eating your own. And I wondered how much you've been involved with people actually growing their own vegetables. That was one question. And for those of us who are football fans, the trauma of the retirement of Arsene Wenger from Arsenal, he was known as having introduced broccoli into English football.
Really?
So yeah, you don't have to answer on that one. That's just, thrown out there. But I'm going to ask Katie Cooper, Carol Baldwin, and Andy Middleton to ask their questions to start with. Katie, yours was a straight question. Over to you.
Yes, it is. This is a straightforward one, although I have a much less straightforward one as well, which I'd like to ask later. It's just, when is the Detroit study going to publish it, and where? Because it sounds absolutely fascinating. I'd love to read it when it comes out.
We are hoping to be able to finish publication before the end of this year. The where is with our academic partners. We're respecting their desires to remain as buttoned up about this as possible. But I promise I'll work with Christine to get everybody's email addresses, and once we have that publication ready, we'll make sure that we share it out to everybody. We're really excited about it. It's very impressive.
I'd really appreciate that. I've just followed you on Twitter as well, so hopefully I'll see
terrific.
it too. But
follow Michel Nischan on Instagram, and you can watch my cooking videos.
There you go.
So I'm nervously introducing Carol Baldwin, who I owe some work to, but hopefully she won't beat me up in public. Carol, can you ask your question of Michel?
Are you on?
Yes, thank you, Michel, for the wonderful presentation. And Christine, no worries. You're just your work is just fabulous. Just really extraordinary. So, and thank you for it. Michel, I live in Arizona. I've lived here for a number of years, and we have several large indigenous reservations. And I've always had a concern. We were doing quality of life studies a number of years ago, including nurses who worked on the reservations. And the only games in town on these reservations were food sellers who sold processed foods, which were cheap, and fruits and vegetables were expensive because in Arizona, particularly in southern Arizona, we're an arid climate. And so, as you know, the rates of obesity are extremely high among our indigenous populations. Are there any plans for doing something akin to what you've been doing, but on the reservations?
Absolutely, and it's an excellent question. I truly appreciate it. I have a number of personal friends who live in First Nation reservations. Terrell Dew Johnson from the Tohono tribe.
Yeah. Mm-hmm. I know her.
State. And we also have a program that we helped COPE launch, funded by Partners in Health in the Navajo Nation. It's been operating now for 4 years. Getting back to our principles of fidelity, equity, and dignity, we're unknown for this work because basically what we wanted to do was share our idea, share the seed funding, and really work with the Dene tribe and the Dene people to design the program and call it whatever they wanted in the community that they call home, because of the incredible sensitivities of exploitation that have been suffered by these First Nations people. And often politicians and nonprofit organizations will come in on the promise of improving the lives of those who live in the First Nations, often to leave, and in their wake, no school was built, no road was built, et cetera. So we literally basically gave them the program as a gift. And if Christine, if you could share Carol's email, I'd be thrilled
indeed
to share with you some of the reports that have come out of that work and the toolkits on how to build a produce prescription program in a First Nation environment. I think, we just completed a produce scan, a field scan of all the produce prescription programs in America, which again, we'll be publishing within a couple of months. But one of the outcomes was, the small number of groups that are actually BIPOC led in BIPOC communities, which is black, brown,
and brown
people of color, and how incredibly under-resourced they are, because that incidence of white privilege actually exists in the philanthropic world as well. And we want to do something about that with this report. So I'll share both with you. It's a terrific question. What we found is that in the supply chain, where these trading posts and these small retailers actually pay almost 2.5 times the price for fruits and vegetables. So it's not just the arid climate and the cost of refrigeration, but our system in the United States rewards large-scale grocers like Walmart and Stop and Shop, who buy pallets of bananas. When you split the pallet, the cost per case goes up about 30%. When you split the case, the cost of that 30% case goes up another 50%. So you're literally paying more than double for a banana in a community that can't afford the banana in the first place. So there's some supply chain opportunities for us all to consider when we look at other stakeholders to bring into this work. Thanks for your question.
Thank you. Very quickly, before I forget, and I don't mean for this to be political, but Deb Haaland, is there any, she's Secretary of the Interior, but now that we have a First Nations person as a secretary, might she eventually be a resource in this area?
We have not been introduced, and I am making a note of that right now. I'm not tweeting everybody. I'm making a note, just so that you know.
So while you're making the note, Michelle, you and Carol are unlikely to manage it, but C3's next seminar is more at our normal breakfast time on 13th of May, and it is addressing the health needs and inequities of underserved people, but from the Pacific area. So a very different population, but we always recall.
But it's all relevant. It's all relevant.
It's more the time you'll have
it is.
with
We've been working in Los Angeles specifically with Pacific Islander community, and it's very similar to Native American communities in that these indigenous communities and populations are recently removed from their indigenous food cultures and exposed to the rampant impacts of highly processed food. We as white people have had over 1,000 years to assimilate to this type of processing of food. And when we look at South Asia, Pacific Islander, Native American, Amazonian, Yemeni, Middle Eastern, it's massive, the impacts on these particular cultures. So very aware, and I don't care what time it is. Send me the invite. I'll give it a shot.
And I'll be there too.
And Andy Middleton. Andy, I'm not sure whether yours was comment or question, but
I guess quite a framing and then a question. So I'm based in Wales on the west side of the UK, Michelle, and we've got a government that's got some really progressive legislation called the Wellbeing of Future Generations Act, which requires public sector bodies to maximize their contribution towards a set of 7 wellbeing goals, which is great news. Part of the problem is they have no idea what maximum looks like. And what excites me is that the kind of examples that you're giving start to calibrate the boundaries of what's possible. And with a colleague who's on the call, Chris, we're starting a project to say, if you took it to the maximum, how many children in your nation would you want to be food literate? And the answer isn't 10% more than last year, it's every single child. And so we've got a project which I put a link to in the chat, which is moving in that direction, which is really exciting. And our short-term project is to take a geographic area with a population of about 1.5 million and optimize the food system for well-being and nature. And I guess what I'd just love to hear, and I'd love to get involvement from anyone than tips, but I'd love to hear from you about, in terms of getting the policymakers on board, I know what you're saying is great, but it sounds too good to be true. How did you persuade people that it isn't too good to be true, and that common sense can become common practice?
That's an excellent question, and I really appreciate you asking it, because it's actually at the kind of core competency of what we do, Andy, and that's that there are 2 ways that you can advocate for something that you see or feel passionate about that's an injustice. One is to really let people be aware and go to policymakers and tell them about all of the horrible things that happen as a result of it is addressed, and how it's inhumane, all of those things that we all know in our gut, we feel in our soul. But the one thing that I've learned over time, and some of it's from being a restaurateur, where we have people from all sides of the aisle eating in our restaurant. They all have to love us and love our food, and we have to listen to all of their opinions successfully if we really want to have a viable business. Lawmakers make all of their decisions based on what's relevant to them, not to us. So when we looked at the SNAP doubling, I'll give you, this is the perfect case study. I really should actually build a slide around this, but when we really got to know, the first thing we needed to do, and this is before we actually established our research protocols, was what are the key decision makers in the agricultural committees of the House and the Senate actually interested in? What do they vote on? And on the right, it was often, we knew what they voted against. They voted against any increases in the food stamp program. They voted for decreases in the food stamp program, but they would vote overwhelmingly for anything that had a demonstrated positive impact on small business advancement, on regional farm economies and farmers, because farmers are often under assault by urban lawmakers in the United States. So they're really interested in kind of the business end of it, right? What's the financial efficacy of the program? And of course, our friends on the left side of the aisle were very convinced about the public health impacts, the lack of, the disparities, the lack of equity, et cetera. So when they actually, colleagues of ours on the left were like, we're really afraid of this notion, because what happens if it turns out to be true that people struggling with poverty don't know about, and even worse, don't care about healthy food, that they're hooked on Twinkies and Coca-Cola. So we designed our studies. We did a retail consumer attitude survey that grocery retailers use in the United States when they introduce people to a new product based on a sale, and then to see if after the sale is over, if they continue to participate. We did economic impact studies on farmers, small and mid-sized farmers, farmers markets, and retailers who participated in the project. When we went to Frank Lucas, who was the Tea Party chair of the House Committee of Agriculture, we didn't talk about that 3,600 SNAP participants, then 5,000, then 6,000 SNAP participants bought more healthy food, felt better about their life, had a positive impact, on their communities, consumed more produce. We didn't tell him about that at all. What we told him was that small, mid-sized farms and retailers invested in infrastructural improvements to their operations, added equipment, hired more people, increased their sales. To Frank Lucas, it was a small business improvement and farm economy improvement program. Had nothing to do with all of the other research that we collected. So in all of our programs, we should always consider what are the multiple truths we can expose as a result of our work, and making sure that we're taking specific outcomes that are going to resonate with a specific lawmaker based on what's relevant to them. And that explains our success with the Gus Schumacher Nutrition Incentive Program.
That's really helpful. Thank you so much. I'd love to connect afterwards, but really helpful. Thank you so much.
My pleasure. My pleasure. Anytime.
Michelle, I'm going to invite two of my C3 colleagues in next. So Natalie, who's our nutritionist, working with me in our French work on obesity and unemployment. And then Michaela, who's doing the work we're doing with health professionals. And then I'm not quite sure whether it's a question, Rachel, you put in the chat, but I feel that Rachel Thompson from World Obesity must have a question for you. So Natalie, then Michaela, and then Rachel.
Michel, thank you very much. It was very interesting. So on a more practical level, so we know that in the more disadvantaged community, very often people may like the cooking skill to cook vegetables because they used to rely on ultra-processed food, and as well to be not equipped as they should to cook from scratch. Mm-hmm. So is that something you did, I mean, to along the program? And did you evaluate that at the end of the evaluation? Is that something you take into account?
So excellent questions. One, yes, we do that. Wholesome Wave ourselves don't do that, but it's required of our community-based organizations who participate to provide nutrition education, cooking education, and in many cases, shopping education, because the notion, especially once you have access to an incentive like doubling your SNAP or produce prescription, you actually have that additional money in your budget. You first of all we've demonstrated that people participate more enthusiastically and participate more in nutrition education and in cooking education. If somebody can't afford broccoli, they're not going to sit through a cooking class to learn how to cook broccoli. It reminds them of the fact that they can't afford broccoli, and actually unintentionally creates racial tensions in a lot of the communities, especially in the urban areas here, just assuming that it's only the lack of knowledge that's preventing somebody from putting broccoli on the table. So the participation in those programs goes up significantly when there's an incentive attached to it. I think when we look at, another point, Natalie, that I think you'll find very interesting is because we have created through technology, whether it's rewards cards or technological apps, and that actually speaks to some of our pivots in COVID and one of the questions, because we can restrict the currency, but it can be used for any fruits and vegetables except for things like canned peaches and syrup, that if you're a Haitian head of household raising a family, instead of forcing you to learn how to use broccoli because it's what the food bank is giving away, you can actually go and buy callaloo and breadfruit at your local bodega. You can make choices that are more culturally appropriate to you. So it actually softens the pressure on cooking and other nutrition education programs, because it gives the option for that educator to say, so tell me and ask some questions. What do you love? You can afford that. Let me show you other things that can have even a more significant impact on your health. and let me show you how to cook them. It changes the paradigm of the conversation. So thank you for the question. I hope I did an okay job in answering it.
Thank you very much, Michel. Thank you.
Pleasure.
So Michaela's going to come back on the broccoli, I think. Michaela, over to you.
I will do, and a few other bits and bobs. Thank you very much. As Christine said, I'm one of the associates here at C3. And I just wondered if you've done anything in the same vein with healthcare professionals or with healthcare workers who often are very low paid and do struggle with access to food. And if you've done, was there ever, I was just thinking, oh, it would be great if they could have some form of prescription that they could spend or use in their setting, in their place of work. And then that would encourage them to learn more about healthy food. And then they'd pass that on to the patients that they see. And yeah, sorry, that was me garbling away, but I think you get the gist.
Thank you, Michaela, for that question. It's a terrific one. And we have not specifically targeted healthcare workers nor restaurant workers. I mean, there are so many workers in our food system chain are very low wage and food and nutrition insecure. We do know that there are healthcare workers who have benefited from our programs. This we know. Most of the multiracial and multi-ethnic communities that we work in urban areas are healthcare workers, hotel workers, restaurant workers, and anybody who's working at a less than living wage that finds themselves relying on federal benefits. We're still at a point here in the US with the produce prescription programs because they're expensive. So it's harder for us to create the movement that we were able to create with the simple doubling of your food stamps for fruits and vegetables, which requires a currency and an accounting methodology that has to be tracked. Here, our healthcare system doesn't provide for somebody who hasn't been diagnosed with type 2 diabetes. It doesn't cover the visit with the nutritionist. There's so many pieces within the system that aren't covered. So for us to specifically target, you have to actually use that system to say, let's target 1,000 healthcare workers in the UCLA hospital system with these particular programs and see if there's a domino halo effect as a result of their exposure to healthy food and how they advise the patients that they're coming into contact with every day. So there's an expense. It's one of the reasons why we're fighting for the healthcare policy. What a lot of people don't know is we've had our success in the federal farm bill. That bill has an economic value of $970 billion over 10 years. Medicaid alone has an economic value of $670 billion a year. And that doesn't include Medicaid, which serves our seniors. So the money is there to be able to support these systems. It's just getting to the point where we can do published studies like the one that Yale Griffin is coming out with so that we can make that case and get that legislation written.
Thank you. Thank you.
Thank you.
That's great. So Rachel, you've come off your video onto your video, so I guess you're ready to ask a question or say something.
Yeah, thank you, Christine, and thank you, Michelle. Mind is blown away. That's congratulations. It's such a pleasure to be on this because I'm sure all of us working in NCDs and public health, we often find we're discussing the challenges and the failures as much as the successes. And it's in obesity and childhood obesity, we're always asked for success stories. What works? Can you prove it works? And it's unfortunately it's hard to prove. So when I heard your words talking about showing a reduce in BMI, it's like it's the holy grail. So I guess my question is really around to reinforce Katie's point on the documentation, and I know we have to wait that way for the academic papers, but in terms of documenting this in case studies and policy briefs, that's what World Obesity we're in the business of kind of consolidating all this. And so that word share, I think definitely want to find out more, but also kind of linked to that, what's the potential for this to go elsewhere? Because I think that's the kind of the burning question for me. Obviously, this is a very context-specific endeavor that has been executed amazingly well, but what's the potential for, I mean, even thinking on other countries in the in the American continent, and how can we start to make that happen? And I think, yeah, there's a lot of amazing learnings that you've shared, like about the framing of it to the right-wing politicians. I thought that was brilliant. The video, yes, I want to share that, but working with the marketing sector more proactively. But yeah, how can we scale this up?
So what we found, and again, it gets back in a way, our principles, the Fed principles, fidelity, equity, dignity, actually kind of ladder into our business model. We had a couple of near misses with the country of Canada with the produce prescription program, but in the early days, where Wholesome Wave is not an endowed foundation, we created a 501c3 nonprofit based on an idea, and then we went out and raised private money, asked people for money, so that we could then turn around and find other nonprofits who are passionate about the idea, teach them how to do it, and then give them the money to do the idea. It's a very expensive way to work. It's effective because we can innovate. We can do things because of our relationships with non-traditional donors that have supported our work over the years, to actually look at different types of technologies that make it possible for people to imagine being very low income and having access to a device that allows you to order food online and have it delivered to your home in a pandemic environment. Talk about implications for stress relief, mental health alleviation, and other things that are suffered in these communities. So, it's not inexpensive work, but we do consult because we do believe in sharing our ideas with folks. And it's what I learned in the nonprofit world, it's happened a lot here in the United States, where you try to go into a state like California and you're not a nonprofit from California, and California donors only want to fund nonprofits from California. This is the same thing working elsewhere. If they're governmental agencies or philanthropic organizations that are interested in launching these types of programs, they're reluctant to fund outsiders to do the work. But we're happy to help any community-based organization anywhere in the world. Take a look at the systems that exist that they're working within. Take a look at the inherent barriers that exist that are not dissimilar pretty much anywhere else in the world. And then share the tools and the kits and the kind of the ongoing advice to develop it out, and then eventually turn everybody loose and go away. When I founded the organization, one thing that you folks probably don't know about me, my last restaurant was called Dressing Room, and I was partners with the late actor Paul Newman, and Paul was the one. The way we did the deal at the restaurant is 50% of the proceeds Paul would donate to the Westport Country Playhouse, which was his passion. Our restaurant was adjacent to it. And I would take my proceeds and do Wholesome Wave stuff. And he said, Michel, this idea is bigger than anything one restaurant will ever be able to do. I have a foundation called Newman's Own Foundation, start a nonprofit and make this a big idea. And I told him my reluctance was, so many nonprofits that I volunteered for never seem to want to get the problem to the finish line. I'll only found this nonprofit if we believe that we can create an environment where we can actually hang the closed shingle out and be the nonprofit that goes away. So we really do believe in solving some of society's most vexing problems permanently. Wouldn't it be great if we could just take one of any problem in the world that disproportionately affects those who are less fortunate than us and make it go away? Wouldn't that be awesome? So anyway, to that, we consult, but when we're done and we do an excellent job, we go away.
That's a challenge for the many of us from on the call from the nonprofit world.
It's hard.
It's
really hard. Well, you guys can be assured your problems are never going to go away. In the US, we are audacious enough to believe that we're going to solve nutrition insecurity.
So I'm going to ask one of the people who you know in the room, Denise, to ask you and others a question, I think, in terms of the work she's doing. Denise, over to you.
I'm actually on the board of Wholesome Wave. And Michelle and I have gone back a few years now working on things, and I actually did some of the evaluation work for the organization, but I'm also with C3. So I kind of cut across both of these right now. And I think in answer to your question, Rachel, which is a great one, is kind of the ones that I've been having in the back of my head too, is how do you take this and spread it further? And I think that's something that's going to have to be on a board agenda to tackle in the future, because that's one of the reasons why I thought it was really important for Michelle to come and talk to a group that is starting to spread outside of North America, because the work that Wholesome Wave is doing is truly brilliant. But Rachel, your question was about partnerships, and it had me thinking about at the ground level, one of the programs at C3 is called CHESS, which is Community Health Engagement Survey Solutions. And it's a community engagement strategy. And we're on the ground working not just with the community members, but we partner with a local organization. And it has me thinking too about how do you take what Wholesome Wave is doing with the produce prescription program and weave that in too, so that anytime you have an organization that's interested in and is working in the community at the ground level, how do you take what Wholesome Wave is doing and make sure it happens, right? And so I don't know, Michelle, if that's something that you have thought about yet?
Yeah, absolutely. Absolutely. There are techniques and tactics to make that happen. When we started, one of the ways that we built the nutrition incentive movement, because of, and you all know this story very, very well, being the leader of a nonprofit organization is like being an entrepreneur. I don't know if any of you saw the movie Groundhog Day, where the guy keeps waking up every day and it's the same day over and over again. I call it Series A Raise Groundhog Day. When you're in a nonprofit organization, you wake up in the morning and the very first thing you think of is raising money, and you spend anywhere from 40 to 70% of your time asking people for money instead of deploying your talent for these types of solutions. When we needed to create the movement, one of the things that we noticed, because there were we were lucky because of my status at the time of a celebrity chef, we got a lot of press on the idea in the early days. And we actually had philanthropists calling us saying, why can't we have a statewide program in Maine? So we went to Maine at the request of a number of philanthropists who were interested in investing, found the community-based organizations who would be most interested in doing this work on the ground, and found that every single one of those community-based organizations was so woefully underfunded by these funders who invited us in, that the grants were so small that these organizations often fought each other over the grants. I call it fighting for table scraps. And therefore were competitive and didn't collaborate because they saw each other as frenemies. They respected the work that they were each doing, but they also saw them as someone who would put their own idea or their own funding at risk. So what we did is we assessed that, and we reported back to this group of 11 main funders that the first thing they needed to do if they really wanted a statewide program was they had to immediately significantly increase the funding that they were giving to these main community-based funders so that they could actually hire people. You don't want a volunteer handling an alternative currency when you have a government that has a wing in it that is averse to fraud, waste, and abuse. You want to hire people. You want to pay them a good wage. So, working with community-based organizations anywhere in the world, it's the same. First, assessing the organizations that are directly connected to those community members and have that trust built, so that the community members that are going to benefit know they're not being exploited because they trust that community-based organization. Assessing and making sure the community-based organization has the staff, the resources, the technology that they need to be able to run a program like this. And then that technical assistance and training on what to do now that you have this newfound capacity. But also, working with the right stakeholders, depending on the government, to really identify who the decision makers are from a policy perspective, so that the research protocols can be designed in a way that we're passionate about a certain type of outcome, but if we really want policy, we need to know who our decision makers are, and we have to study towards that. We can study and gather all of those other outcomes that are publishable, et cetera. But if we want policy change, we really have to lean into the fact that we got to convince people many of whom no longer believe in science. So I hope that was helpful. That was a great question. Thanks.
I'm going to leave the last question to Katie, who we've managed to go for almost an hour without mentioning COVID-19, but Katie's going to challenge you on that. Over to you, Katie.
Yes, I've been working for the past year with the Access to Nutrition Initiative on a series of reports looking at the big food manufacturers and their response to COVID. So I'm really interested in the ways that COVID's had an impact. And it feels like there's this contradiction between relatively robust food supply chains, but also this sort of terrible and growing inequity and food insecurity. So how did your program adapt to the initial crisis? And also sort of where is it settling now, and what are the lessons that you've learned from this sort of crisis over the past year?
Yes, thank you, Katie. I appreciate that. When COVID hit, we freaked out. So many of our alternative currencies were in the form of coupons, tokens, rewards cards, requiring a population that was already at risk because they had multiple of these comorbidities that were hospitalizing and killing people who encountered the pandemic at the highest rates, caused them to be at risk to get their healthy food. We were very fortunate to be working with an initial technology partner that had a technology platform that would allow people to order food online for home delivery. It was actually so powerful, the promise of it was so powerful, that we were selected by the LA County Department of Health at the end of the year last year to do a program using CARES Act funding from the previous administration. And it was actually intentionally done at the end of the year because it targeted undocumented community members who were suffering at the highest rate because they don't have access to the federal food assistance programs and others that can help them. So LA is a sanctuary city, and they were audacious enough to say, let's try to squeak this in under the wire, hoping that there might be an administration change. And we basically reached 97,000 low-income, undocumented Angelenos with about $21.7 million in food benefit as a result of this technology. Since then, we've encountered a really solid technology. These folks actually made a pivot as a result of COVID. It's called Foodsmart. You can look them up on the internet. This is a company that was founded as a white-collar insurance employer wellness platform. In fact, the House of Representatives of the United States is a client of theirs, where they work with nutritionists. They have a software that connects to all available electronic medical records systems. Really worked out a platform that uses grocery retail SKUs from over 34,000 grocery retailers in the United States. And between the survey that the nutritionists conduct with employees or now patients that onboard, that algorithms out with the electronic medical record system and then spits out a food plan based on cultural preference, allergies, and then the health outcomes from the EMRs. And then that food plan, when you click on recipes in the food plan, gives you a shopping list that you can take to a retailer. They went online. I've known Jason Langeyer for 10 years. And we tried to work together, but he was building a new company and had to do subsequent financial raises and had to drive economic value in the valuation of his company. So he couldn't engage with individuals and he couldn't engage with low income. They've hit some milestones. in the past year that now have allowed them to go into the Medicaid space and also to onboard individuals who can benefit from Wholesome Wave programs. So we're beginning to partner now with Foodsmart. And this gives us quite an opportunity because they do partner with Amazon, they do partner with Walmart online, but they also partner with Instacart. So local grocers, independently owned groceries, bodegas, anybody who has a POS system that can integrate with Foodsmart, and they've built it for very broad integration, can benefit from the platform through Instacart. The interesting thing that I found, Katie, in the system of Walmart and Amazon, these large companies doing food stamps online, is that without the nutrition incentives, their healthy food is just is less affordable online than it is the unhealthy stuff, because to buy food online, it isn't free. It's more expensive than buying it at the grocery store. But we do see the nutrition incentives as being powerful and allowing people to engage more broadly and being able to tap into that type of technology that can allow them to get the food they need in a pandemic environment and avoid the contact that a lot of these programs tend to cause. It's a long answer, I apologize. My mom always said, if you ask Michel what time it is, he'll tell you how a clock is built.
And on that, thank you so much, Michel. So often people who come to give a seminar give a lecture and leave a couple of minutes at the end, but you really stimulated some great questions, some brilliant answers to the great questions. So I think everybody will enjoy refreshing themselves looking at the recording. Thank you so much for your time. Thank you to all the participants. It's been a really great hour. The recording will be sending you so you can refresh it. And Michel, thank you. Thank you to our sponsors,
My pleasure. Thank
Cancer
you all.
Research UK and the Burdett Trust for Nursing. And hopefully we'll see many of you again, 8:30 UK time on May the 13th. Many thanks, and thank you especially, Michel. Bye.
Well,
Thanks,
thank
bye.
you.